Good evening, everybody, and welcome to the first WHWB webinar of 2024. We are very pleased that you're all with us. It gives me such a great pleasure to have you all here tonight, except for those in Australia. It's very early in the morning. I believe it's Wednesday, and if I have that wrong, I apologize. We have three really brilliant scientists who are going to share their work with us tonight. And they are Paul Demers, who was the chair of the IARC panel. Deborah Glass is a very strong epidemiologist from Australia. And Kenny Fent, who is the a toxicologist and a public health officer at the National Institute for Occupational Safety and Health in West Virginia, I believe, right? At any rate, I'm going to give you some very brief slides to get things going, and then I'm going to turn it over to Dr. Demers. I just would like to say briefly that it has been my pleasure to have been a past president of Workplace Health Without Borders in the US, and I'm on the faculty at George Washington University in Washington, D.C. Just a few housekeeping chores. The views of our speakers, they are not that of any organizations that are assisting with this webinar. The speakers are speaking on their own, and I very strongly urge everyone to read the 2022 Lancet article that summarizes the work of this IARC panel. And secondly, to go into detail and look at the larger IARC panel, volume 132, which was published late in 2023. And I've given you those, try and click on them if you need to do so. And I also want to say that I've been a consultant to lawyers representing both plaintiffs and defense in firefighter cancer cases in the United States. Okay, so I have posed a question to myself because I have worked on an IARC panel some time ago evaluating the cancer risk from silica dust in the 1980s. So the question is, why are they so important for us, especially in public health and medicine? And there are, in my opinion, three important reasons for this. One, they reflect the current shared knowledge of the world's medical science and cancer experts focusing on the findings related to causation factors. In other words, they focus on what the epidemiology tells us, in this case, about firefighting cancer risks. The second is that the IARC report lays out areas needing future research in mechanisms in toxicology, industrial hygiene, prevention, and cancer medicine. And lastly, the review process is open, opaque, accessible, and it's also changeable when there's new evidence that comes forward. And one of the things that people from outside of the sort of IARC process perhaps don't fully understand is that the scientists who provide these discussions rely on peer-reviewed publication for information that they are sharing in these IARC reviews. So I have just a couple of other notes. I have the deepest gratitude for my experts that you're going to hear in the next hour. I mentioned Dr. Demers, who was the chair of the IARC firefighting panel, Drs. Deborah Glass and Kenny Fent. Each speaker will have about 15 minutes, and we will have time for questions at the end. My hope is that you will take advantage of the process that Zoom gives us to type in your questions and just hold on to them. We'll try and make sure at the end that we get those from the chat box. And we would also welcome your feedback about this whole process. I'm going to try and be pretty strict about the time. And as I said before, this is being taped and it will be accessible on the WHWB website. So my greatest thanks goes to all of you for joining these webinars, and please look out for new ones coming in 2024. Lastly, I would very much like to invite you to become members of WHWB. And for those of you who are in the US, please join Workplace Health Without Borders US. Your membership makes all this possible, and I am very grateful for that. So we're gonna, as soon as I get done, Dr. Demers will go ahead and speak. That will be followed by Dr. Glass and then Dr. Fent. And we hope to have a little bit of time for your questions. The roundtable, those who came a little bit late, we will certainly go past 8 o'clock to try and answer the question globally, where is firefighting and cancer effort going? And lastly, I would just very much like to say enormous gratitude to Marianne Levitsky, who is the past president of WHWB, Jennifer Galvin, who is the current president, and Audrey Cunningham for making all of this Zoom activity possible. So I'm going to stop share and turn this over to Paul.
Okay, thank you, David. Let me share my screen. And then hopefully, are people seeing it?
Yes.
Okay, very good. So hello, everybody. Good evening or good morning or something in between. I would today I'm going to talk a little bit about the IARC process and give you a brief summary of the evaluation of firefighters. And I'm going to move my camera over to where my screen is, although you don't need to look at my face. The International Agency for Research on Cancer, for those of you who don't know, was created in 1965. It's a specialized agency of the United Nations. It's attached to the World Health Organization, but it's actually, traditionally it was funded by higher income countries, and now a variety of different countries, many of the larger countries in the world are also funding the IARC program. So it's a little separate from the WHO and a little independent in that way. The first monograph was published a little over 50 years ago, and these monographs were really designed to evaluate the carcinogenicity or present the evidence on the carcinogenicity of different substances that were evaluated. The actual evaluation is done not by staff, but by what's called a working group. It's called a working group because they do a lot of work over a period of time. People are recruited about 9 to 12 months prior to an evaluation. Currently the process is that the first drafts are produced 6 months prior to the evaluation, and we continue refining those. And in the end, we meet for about 8 days to actually talk about and come to some kind of consensus, if possible, about the carcinogenicity of whatever we're reviewing. There are 4 subgroups in a working group. One is on exposure, one is on cancer in humans, which is focused on epidemiology. One is on cancer in animals, which is kind of obvious. It looks at experimental studies. There were no studies related on that to firefighters, but typically there would be a subcommittee on cancer in animals. And there's another on mechanistic evidence that reviews studies that examine whether the hazard displays the key characteristics of human carcinogens, such as genotoxicity, epigenetic alterations, oxidative stress, and a number of others. So the exposure group kind of supports all of this in terms of presenting where the particular hazard or agent, as we say in IARC evaluations, is found, and its properties, who's exposed, and those kind of things that are really essential for kind of tying the evaluation together. Now, sometimes you hear critics of the IARC process say, well, they think everything is carcinogenic. In the 51 years that IARC has been operating, they've reviewed 1,046 different agents, and they place these into 4 classifications. Group 1, which is carcinogenic to humans, only 12% of all the things that are reviewed by IARC get into this category. And that's significant because everything that's forwarded onto IARC is either proposed by government agencies or international experts as having some evidence of carcinogenicity, something that makes people worry that it might be carcinogenic. And still, only 12% of those are classified as carcinogenic, group 1. Another 9% as probably carcinogenic, 30% as possibly carcinogenic, and almost half as not classifiable. That is, that after the group reviews all the evidence available, they decide that there isn't enough evidence to say even that something is possibly carcinogenic. So it's actually a very tough process that everything goes through. Now, firefighting was first evaluated in 2007 when 24 scientists from 10 countries got together. I had the privilege of being part of that evaluation. The conclusions, though, of that evaluation were that firefighters are exposed to, known, probable, and possible human carcinogens, group 1, 2A, and 2B, and that there was limited evidence for testicular cancer, prostate cancer, non-Hodgkin's lymphoma. But the overall conclusion was just that firefighting was partially, possibly carcinogenic to humans. So that's group 2B. So that was in 2007. And if we go forward, in 2019, an IARC monograph Priorities Advisory Committee group met. Now, every 5 years, IARC pulls together an international group of experts to, take in the recommendations from a wide variety of people around the world and try to decide what is going to happen over the next 5 years. And as David was saying, the process is such that when new evidence becomes available, things get reevaluated. If this advisory group actually concludes that there's the possibility that the evaluation could change. In this case, there were new epidemiologic studies that were published. They were, better studies, longer follow-up, greater numbers of people. And importantly, they were reporting more similar results than some of the studies published in earlier years. So there was a thought that perhaps, there were cancer sites that we could converge on in terms of deciding the evidence was strong. There were also a number of new mechanistic studies of various kinds, increased DNA damage, oxidative stress, epigenetic changes, and activation of cancer pathways. On the basis of the availability of this new evidence, it was recommended that we go to reevaluation within 2.5 years. Now, that was 2019, the fall of 2019, 6 months later, COVID hit, but still 3 years later, another monograph working group was convened in June of 2022 with 3 different subgroups to review all the evidence that was available and to evaluate exposure as a firefighter. So we did go forward and reevaluate. In this case, there were 25 scientists from 8 countries, 3 of whom are here this evening. Now, they concluded, or we concluded, as was done in 2007, that in fact, firefighters are exposed to many group 1, 2A, and 2B carcinogens. And all types of exposures were considered, not just those from fires, that is combustion products, but also diesel exhaust from equipment, the presence of different building materials that might be released, chemicals that are used, but also shift work and even exposure to UV radiation while fighting fires. And we looked at evidence not just for structural firefighters that people might typically see a lot of the publications from, but also in terms of wildlands firefighting, and a variety of other different firefighters were considered in terms of exposure. There was, I will say, strong mechanistic evidence for 5 different mechanisms. That is, that the working group concluded that there was sufficient evidence that firefighting caused genotoxicity, epigenetic alterations, oxidative stress, chronic inflammation, and modulation of receptor-mediated effects. Now, It is a very interdisciplinary or multidisciplinary committee that reviews, and I am not, I was not a member of that subgroup, so I won't be able to answer difficult questions there. But this was a lot of different cancer mechanisms, so this was a very important piece of evidence. When it came to epidemiologic studies, there were indeed a lot of different studies available, and cohort and case control studies, but also some case reports were considered. And a lot of previous meta-analyses were also looked at. But we also chose 13 cancer sites for our meta-analyses just for this evaluation and for in-depth review. And you see them listed here. It included stomach, colon, lung, melanoma, mesothelioma, prostate, testis, kidney, bladder, brain, thyroid, and non-Hodgkin's lymphoma, as well as all cancers combined. So a lot of different cancer sites went under scrutiny for this. A meta-analysis, this is what, just to give you kind of a graphic presentation of this. This is for mesothelioma. There were not a lot of studies that had mesothelioma, but this was many more than the previous evaluation, where I'm not sure any of these were published at that time. Actually, none of them were, because you need big studies to look at mesothelioma in terms of firefighters. And what we saw was a very consistent pattern here, not much heterogeneity. Because this is brief, I'll just say that the numbers that you see on the right are different measures of relative risk with 95% confidence limits, and then how much weight they had in the overall analysis. And then the meta-relative risk is at the bottom. So 1.58 was the meta-relative risk with low heterogeneity. So here you see all the different cancers that were looked at. Well, not all the cancers, because I wouldn't be able to fit all those on a screen, but the ones that kind of rose to the top in current terms of evidence. Mesothelioma and bladder, particularly another 5 cancer sites there you see. I just put lung and all cancers at the bottom to show you that not everything came out consistently elevated. And surprisingly, lung cancer did not, and all cancer sites did not. But colon, prostate, testicular melanoma, and non-Hodgkin's lymphoma also had, a degree of consistency and statistically elevated risks when you looked at studies that used cancer registries rather than just death certificates. The final evaluation was that there was sufficient evidence for mesothelioma and bladder cancer. Mesothelioma was consistent, although there wasn't a lot of heterogeneity. 6 of the 7 studies found an elevated risk. These were well-conducted studies, large studies. And even though there's not a lot of measurement of asbestos at fires, the fact is that a lot of structures have fires, and when those structures burn, we know that that the asbestos is released, and so that there is exposure, the potential for exposure during all phases of firefighting. In the case of bladder cancer, there were consistent positive findings in well-conducted studies. But we also know that there are a lot of the exposures that firefighters experience are associated with bladder cancer, including exposure to polycyclic aromatic hydrocarbons, soot and diesel engine exhaust, as well as aromatic amines. And in terms of worrying about things like cigarette smoking, well, we did not see the same elevated risk for lung cancer. And when you don't see it for lung cancer, it's hard to say that this is a high, smoking population. And in fact, there is evidence from some surveys that in fact firefighters smoke less than the general population and not more. The other cancers had limited evidence. Now, that's not to say that there was no evidence. In fact, there was a degree of consistency there, but not enough to draw final conclusions. And a lot of other factors were considered. Not just consistency, but were there known exposures there, which there were for some? Did the risk increase with number or duration of exposure, things like that? We also considered the impact of medical surveillance or early detection of some cancers. and then some other issues as well. But here you see the next 5 strongest cancer sites. And just to keep us on time, I will wrap up there and turn it over to my colleagues.
Thank you very much, Paul. Dr. Deborah Glass is our next speaker.
So I've been involved in some studies of Australian firefighters. These are my co-workers here. And yes, it is Wednesday morning, so we are the future. So what have we done in terms of the studies? Well, we had a national study with 8 out of the 10 state and territory-based agencies and then a federal agency, Air Services. What are the advantages of doing studies like this in Australia? Well, first of all, it's a very highly regulated environment here, and there's national reporting through the Productivity Commission. There's a link there. And you can look up how many firefighters, how many volunteers, how many paid, how many incidents they've attended. There's an enormous amount of detail there. That's the 2022. There will have been an update since then. There's also a National Council Oversight, AFAC, the Australasian Fire and Emergencies Commission. No, I've got that wrong. But so there's a coordinating body that joins up the various agencies across the country. And you probably know, but Australia is about the same size as the US in terms of land area. So it's a very large country, but comparatively sparsely populated. And AFAC run or collate the Australian Incident Reporting System, AIRS, which I'll explain a bit more about, but it catalogues the incidents that are attended by the different agencies. We also have a national death and cancer registry system here, so that if you work in Victoria but retire to Queensland, you'll still be found on the system. So it's a national system, and it's got a very high trustworthy and complete system. The cancer registry, it's a legal requirement for when cancer is diagnosed for it to be reported. So again, that's very complete, although it doesn't include the non-melanotic skin cancers, which are so common here. We are currently looking at PFAS exposure and firefighter health. It's proving to be quite a difficult study to do because, of course, you have to take into account all the other exposures that firefighters have had alongside the PFAS exposure, which may be affecting them. So we're having to try and tease out the extent of exposure on an individual basis for the firefighters in the study. So in the original study design, we assembled the cohort from existing fire agency records. They had obviously name, address, date of birth, that kind of thing, but it doesn't have data on individual risk factors like smoking and ethnicity, which can affect risk. We had an advisory committee of stakeholders from the unions and volunteer bodies, and as well as the agencies, who could provide information on how things were done, because obviously we're outside the fire community ourselves, so we needed some experts from within. We also had a technical reference group that could reflect back how we were doing in terms of the science. It was a pretty large study, over 200,000 people. You'll see that there's a very large number of volunteers compared to the paid firefighters, and quite a small proportion of them are women. So we were not able to say much about the paid firefighter risks, because 1,600 women produce a relatively small number of outcomes, actually. And in epi studies, big is beautiful. Now, the difference in terms of fire stations is we have these kind of large urban stations, but we also, for volunteers, have these small fire stations in rural communities. So here's a fire station that's smaller than the local second-hand shop. So small communities, but these are all coordinated via there are 2 volunteer-only organisations in 2 of the states, and then 2 of the states, they're part of the state alongside the paid firefighters. So although they're small, the data collected is done very systematically. So the incident data is a really terrific resource for someone like me as an epidemiologist. They collect and record and report attendances, and they're recorded at the time, so there's not a recall bias. You're not saying to people, how many times did you turn out? And there's a standard computerized data set, which is reported to AFAC. At the agency level, it's linked to individual firefighters. So the names of firefighters who have been to different numbers of incidents are recorded. Those individual names are not passed on to AFAC, so they're not known nationally, but we could get hold of them. And in 1990, when we collected it, the data comes from 1990 onwards. So in 2010, when we looked at it, there were about 2.5 million records. So you can imagine that was a lot of organisation. It included all incidents, including false alarms, but the fires themselves are categorised into structural, landscape, vehicle, and then there's another group. If you look, this is a log scale across the bottom, at the total incidents that people have been to, full-time paid firefighters, you know, we're averaging over 1,000. There's obviously a tail here of newly recruited firefighters. So by the time you get to be an experienced firefighter, you've been to several thousand incidents. The part-time paid people, unsurprisingly, have a smaller number, averaging, well over 100, but going up to over 1,000. But the volunteers are particularly interesting. You can see there's a group here of firefighters who've been really to no incidents. And so volunteers can become part of the volunteer bodies and not turn out. And there's a couple of reasons for that. One is that they may join to become trainers or to become fundraisers or do paperwork. They're often a centre of a community. The second reason is that in places like Queensland, someone may do the training and become part of the volunteer, but they're never actually called out because the properties there are so huge that by the time they get to a fire that's not on their property, it would be out. So there are, particularly in Queensland, huge areas, do the training to look after your own property, but you're not really called out. At the other end of the scale, you can see there are some volunteers who've been to over 1,000 fires, and that's particularly in places like Victoria, the state that I live in, which is relatively small. It's got has a reasonable number of bushfires, unfortunately, and volunteers can get called out really quite frequently. So what kind of incidents do people attend? Well, there are different proportions. So you can see that part-time paid firefighters tend to get called out to fires rather than to non-fire incidents. So they're not they're on call and only go when they're really needed. So they seldom get called to things like false alarms. They all get called out to landscape fires, but the career full-time people are more likely to be attending structural fires than to bushfires, which are out in the countryside. But they all get called out to about the same number of vehicle fires, same proportion of fires, I should say. Sorry. So we compared risks to the general population in terms of and they're obviously age matched. So we're looking at standard mortality ratios and for cancer incidents. So we didn't particularly go into the mortality from cancer, we were looking at incidents. We could compare risk between firefighter groups, giving us the relative mortality or the relative incidence. So we can look at duration, incidents attended, we can look at trend tests, but we can also look at when people went. So the analyses were adjusted for age and calendar year, and we looked separately at men and women and career, full-time, part-time, and volunteers. And in the report, there are 62 tables like this. The blue means it's statistically significantly reduced risk, and you can see a much reduced risk of all causes of death and of all malignancies. and that's not uncommon in industrial cohorts. That's called the healthy worker effect. Particularly, you get a healthy worker effect in spades in firefighters, because firefighting agencies can be very selective about who they produce, and they don't select unfit people like me, let's say. We also think there are, as Paul said, there are likely lower smoking rates, but we don't have individual smoking data. But looking at the lung cancer incidence, it's low. And we didn't see increases in cardiovascular respiratory death, which would also be related to smoking risk. But we did see attendance at fires associated with an elevated RMR for circulatory causes compared to those who attended fewest fires. And that's one of the advantages of being able to do within cohort comparisons, these relative mortality risks, that you're comparing similarly highly selected group with another similarly highly selected group by the extent of exposure. And that's a way of examining the extent to which the healthy worker effect is going on. Interestingly, we didn't see elevated RMRs in association with duration of employment. So it does look like it's not how long you serve, but how much you did while you were there. In terms of cancer, you can see there the red is a significant excesses, the respiratory is significantly low. And what we found for male career firefighters, that the overall cancers were raised, particularly for those who had more than 20 years of employment. Didn't see a duration trend in the relative risk, but we did see a trend in relation to the number of vehicle fire incidents attended, which I think is interesting because they certainly have a lot of nasty stuff coming off vehicle fires. Prostate cancer, the overall SIR was raised. We saw an increased risk with more than 20 years of employment. We saw a trend with duration and a trend with incidence. And these are age adjusted, because obviously a big risk for prostate cancer is age. So these are taking into account age. Melanoma, we saw an overall increased risk of incidence. It was raised for those with more than 10 years employment, and it was raised for all eras of first employment. So there's been a lot of work done in terms of public health prevention, slip, slop, slap campaigns to try and get people to protect themselves from the sun here in Australia, but we didn't see an effect of that. The volunteer firefighters are a slightly more difficult group to look at in many places. The record keeping may not be as good as it is for paid firefighters, where, you know, if you're paying someone, once you stop paying them, they come off your payroll. That might not be the case for volunteer firefighters, but we did look at risk for those over 85, and we found it's likely that there were very few immortal firefighters, so we think the record keeping was good. They are, of course, mainly based in rural communities, and they have different demographics from the urban community, which are the majority of Australians, so we need to be a little bit careful about the comparisons. Another reason for why within cohort comparisons of volunteer was important. There are likely to be fewer ethnic minorities in rural Australia. Ethnicity data is not collected by the agencies, but of course it does, for example, affect melanoma risk. And of course, these volunteers will have other jobs, often outdoors, so maybe they have pesticide exposures. But we also found a number of the volunteer firefighters were also paid firefighters, so those people were removed from the volunteers and put only into the paid cohort. And of course, there's more driving in rural and regional areas, which may result in more accidental deaths. The death registry doesn't distinguish what you were doing when you died. So it could be that you were driving to a fire, but more likely you were driving home from the pub. So in summary, we found overall increased mortality related to the service was unlikely. Too few female paid firefighters to draw many conclusions, but there was an increased risk of cancer for male full-time firefighters, fairly clearly with prostate and melanoma, plausibly with male breast, LH, kidney cancers, and possible associations with testicular and mesothelioma. So we found increased risks, but they weren't statistically significant or didn't show up in these internal comparisons. For male part-time, similarly, prostate and melanoma, but then a slightly different suite of other possible associations. For male volunteers, again, prostate, which is interesting, but also testicular and kidney. And for female volunteers, possibly melanoma. And the smaller number makes the risks harder to demonstrate if they exist. So the reports are at this website, so you can see the full 62 long tables if you want to have a look at them. We also have looked at the risk for defence firefighters, in particular the RAAF, what do you call them? I think they're flying aeroplanes. Yes. We also did a cancer cluster investigation in Queensland firefighters and investigation of cancer at a fire training college where there was a fair amount of use of the PFAS foams. And there are some publications where you can follow up a more selected, if you want to read something shorter than the full reports. That's it. Thanks.
Thank you very much, Dr. Glass. I think you have contributed a great deal to giving us several things to consider. And now I want to turn it over to Dr. Kenny Fent, who is, as I said, from NIOSH, the National Institute for Occupational Safety and Health. Go ahead, Kenny.
Thank you. Hello, everyone. Honored to be here. My name is Kenny Fent. I'm a research industrial hygienist by training. I'm the manager of the Firefighter Health and Exposure Research Program at the National Institute for Occupational Safety and Health, or NIOSH, in the United States. And I'm also the head of the National Firefighter Registry for Cancer program, which is what I'm going to be talking about today. So in the United States, we have around 1.1 million firefighters that protect our communities and the environment. We have around 1.4 million fires every year. Around 500,000 of those are structure fires. And that basically encompasses about 1 to 5% of a firefighter's time is spent at a structure fire, accounting for about 20 to 100 hours per year. There is quite a bit of variability, just like we heard from Dr. Glass. We see higher, incidents attended from career firefighters than volunteer fires generally, but there's a lot of variability. In the United States, we are also seeing a wildfire season that's growing in length and severity, and this is happening across the globe. And a lot of those wildfires are also encroaching on urban areas or residential areas and creating a mixture of both vegetation and structure fires in what we call the wildland-urban interface, or WUI. And that produces a lot of different hazards, which we've already heard some today during the presentations, but hundreds of combustion byproducts, dozens of recognized carcinogens, PFAS, which we heard. PFAS is in a lot of different man-made materials and is released. It's also used in certain types of firefighting foams. Flame retardants are released. And then firefighters are also exposed to shift work and even synthetic materials that are not combusted but are released into the environment. So if we look at compounds or agents that have been measured in the fire ground and we compare it to what IARC has evaluated, there are a number of compounds that are IARC Group 1 known carcinogens. There are, I think, up to 8 that are Group 2A probable carcinogens, and then there are 18 chemicals that are Group 2B. And just like Dr. Demers mentioned, these aren't all chemicals. So there's also UV radiation, there's shift work, there's a number of other kind of hazards that we're also concerned about in terms of cancer risk for firefighters. So we've heard a little bit about the epidemiology studies. One of the largest studies in the United States was conducted by NIOSH. It's what we call the 3-city cohort study. It included around 30,000 firefighters from 3 large metropolitan departments. And that study found excess cancer deaths and diagnoses compared to the general population. And those were primarily respiratory, digestive, urinary, and oral cancers. There have also been case control studies that look at state cancer registry data as well as death records, and those have found associations between firefighting and specific cancers, but those have varied by state. There have been a few studies that have looked at cancer risk by sex and race, but many of those studies were limited because of small sample sizes, especially among women and non-white firefighters. There are also limitations with some of the records-based studies, which most of these are records-based, just in terms of getting accurate estimates of exposures over time, and then lost to follow-up, because if you're a firefighter and you work in one state but you retire in another, that creates problems because we, unlike Australia, we do not have a national cancer incidence system in the United States. And then we've heard about the meta-analyses that have been conducted, and many of those have shown evidence of a link between firefighting and specific types of cancer. And one of those meta-analyses was done by the IARC working group that found sufficient evidence for mesothelioma and bladder cancer, and then limited evidence for the 5 other cancers that were noted by Dr. Demers. So even though IARC has found evidence of increased risk of certain types of cancer, there are still a number of questions that remain. And these questions can really be categorized into 3 different groups here. So first, what is it about firefighting that increases the risk of cancer? How many different types of fires firefighters attend, the exposures coming from those events, including major events. So we worry about the Whwb fires, the wildland-urban interface, also industrial fires, train derailments, all sorts of unique exposure events that firefighters can have. There are, of course, chemical exposures, but there are also non-chemical risk factors. And then, fortunately, many fire departments across the country and the world have started to implement specific control measures to reduce firefighters' exposures, at least chemical exposures. And to what extent are those lessening the risk of firefighters' cancer? The other group that we need to answer is how does cancer vary across specific groups of firefighters? So by demographics, women and minorities, the different specialties of the fire service between volunteers and wildland firefighters, and then just generally across the country. You see different risks, cancer risks regionally across the country, and that may hold true as well for the fire service. And then we heard from Dr. Demers about rare forms of cancer. To really be able to detect rare forms of cancer, you have to have a very large population that you can follow over time. And then we're also interested in answering questions about non-firefighting characteristics and behaviors and how that relates to the risk of cancer. So that can include things like diet and exercise and other health behaviors that firefighters may or may not have. And so these questions really motivated the Firefighter Cancer Registry Act in the United States, which led to the development of the National Firefighter Registry. And it mandated that the Centers for Disease Control, which NIOSH is one of the institutes within CDC, that we develop and maintain a voluntary registry of firefighters to collect both health and occupational information to determine cancer incidence. And so our mission is to generate detailed knowledge about cancer in the fire service through a voluntary registry that reflects our nation's diverse fire service. And then to take that knowledge that we gain and give it back to the fire service and public health communities so that they can take that information and hopefully reduce the risk of cancer among firefighters. So the key components of the NFR are to collect self-reported information about firefighters and their work through a secure online portal, to obtain records from fire departments, to track trends and patterns of exposure, to link with health information databases, including state cancer registries and the National Death Index to look at both cancer diagnoses and death, and then to make de-identified data available for external researchers. In terms of who is eligible, the NFR is open to all firefighters in the United States, both active and retired, and you do not have to have cancer to register. And it's actually really important that we have firefighters without cancer who register, because we really want to know, we need that to be able to look at cancer incidents, and we want to know why some firefighters develop cancer and others do not. The participation is voluntary. We do have an emphasis on women, minorities, and volunteers who have historically been underrepresented in research, and they are specifically called out in the Act. And then we're also interested in all those subspecialties that I mentioned, including wildland firefighters. And our goal is to enroll 200,000 firefighters over the next several years. So enrolling in the NFR is really straightforward. Firefighters will visit the web portal, nfr.cdc.gov. They will confirm their eligibility, click the login button, create an account, sign the consent form, and then fill out a questionnaire. And the questionnaire includes questions about demographics, health history, and lifestyle. But the part of the questionnaire that takes the longest is the work history section, and that's mainly because we really do need to know what firefighters have done throughout their work history, how long they were a firefighter, how many different types of responses did they attend. So that's all part of the enrollment process. Once firefighters enroll, we will be periodically linking them to state and federal records, including the state cancer registries, which provides information on cancer diagnoses in those states. So we'll be linking to all 50 state cancer registries. We'll also be leveraging the North American Association of Central Cancer Registries virtual pooled registry, which is a streamlined way of simplifying that linkage process. And that will help us to determine cancer incidence. And then we'll also be linking periodically to the National Death Index so that we can look at different causes of death. We are required to make the data publicly available or available to external researchers, but also maintain and protect firefighters' privacy. And so we have obtained an assurance of confidentiality, which is the highest level of protection for this kind of data. Basically means we cannot share individual identifying information with anybody without express written consent from the individuals, but we can make de-identified data available to external researchers through a secure mechanism. And we are actively pursuing this through research data centers. Some of our other ongoing efforts is that we are working with specific fire departments to obtain roster information from the fire departments, and then encouraging participation from those firefighters, what we call the targeted enrollment method. And the advantage of that is that we can actually look at participation rates and hopefully address some of the limitations with an open enrollment with respect to selection bias. We are actively pursuing both exposure and incident records, accessing those records. There will be opportunities for follow-up questionnaires where we can look at specific topics longitudinally. And those follow-up questionnaires, we may, produce one a year, if that, but it does provide that opportunity. Those would be much shorter. And then we're in the process of building a data visualization dashboard that would provide, near real-time statistics that would be of value, but for both firefighters and fire leadership. And then, our ultimate goal is to reduce firefighters' risk of cancer. And so we are wanting to communicate with participants via email and text messaging with the latest information, best practices, cancer screening guidelines, and things like that. So obviously for the NFR, because it is a voluntary registry, for it to be successful, participation is key. We officially launched in April of 2023. And as of this month, we have nearly 10,000 firefighters who have signed up, which is a good start. But we have a long way to go to get to the 200,000. That is our goal. And so we have a robust communications plan where we are developing videos and fact sheets and posters and social media content, and working with professional fire service organizations in the United States to really push the information out to firefighters all over the country. And then we're also developing training modules because, again, we want to help reduce firefighters' risk of cancer. And one of those training modules was developed with the Fire Safety Academy, and the URL here provides that training module. And it basically provides information on different ways that firefighters can reduce their chemical exposures. And so that's all I have. The QR code here does take you to the web portal if you want to see what that looks like. The website provides a lot more information, including all the different communication materials. And I'm happy to answer questions when we get to the Q&A stage. So thank you.
Thank you very much, Dr. Fent. So now we've come to the time when I'm hoping that we'll have some questions. Please recall that we'd like you to put them in the chat box. I've got a couple of people who have already sent me some, and I'm just remind everybody when I call on you, please unmute. Francis Ehrlich, I believe you have a question. Please start off.
Thank you. Deborah's already addressed my question. I just wanted to know whether the graphs included false alarms, because we do have a high percentage of those in terms of turnout data. But Deborah kindly explained there's still potential exposures associated with false alarms as well.
Right. The next question, I think, comes from Daniel Samo. I hope I'm not mispronouncing your name.
No, you did great. My name's Dan Samo. I'm a physician in Chicago at Northwestern. Originally ER, now doing OCMed. Been on the NFPA 1500 technical committee since 1996, and so deeply involved in this. But I have a tripartite question. Part of it is, as I do a lot of IMEs, testify a lot about this, and I'm always presented with one study that showed, what the lawyer is trying to convince everybody of. But how do we explain to others, to lawyers, jurors, and others, the huge disparity in the different studies that are out there, and the hugely different results that are out there? So that's number one. Number two, also, how do we explain the fact that these studies rarely, if ever, control for confounding factors, smoking, obesity, other exposures? Example, a lawyer showed me a study that showed that firefighters had more head and neck cancer. It was the only study that said that, but it supported his point. But of course, the study wasn't controlled for HPV, leading cause of head and neck cancer. And so that's another thing. And then I guess last is, why are we doing this? What is it that we hope to gain by doing these kinds of studies? when we know that firefighters are exposed to carcinogens. The problem is they're exposed, not trying to prove that this cancer or that cancer is caused by this or that exposure. Should we not be putting our efforts more into studying how we can reduce the exposures through process changes, through PPE, and through engineering controls so that firefighters are not exposed? And lastly, which we don't have to talk about, is presumptive laws, which all require us to come in and say that there was, that this was caused by firefighting, even though it's presumptive. So I'm sorry, it was a little bit of a speech, but those are my points and questions. Thank you.
Paul, do you want to respond to that?
There was a lot to respond there from Daniel. What I will say.
That's why they made you chairman of the IARC panel.
Yeah. Well, one thing that I will say is that when IARC looks at the evidence, we look at the weight of evidence, so that we look at all the studies that meet our quality criteria and try to look at consistency across those studies and take into consideration a lot of other things. That makes it, I think, a tougher hurdle to get over in terms of drawing the kind of conclusions that sometimes people want to hear from an IARC committee. But the fact is that it means that the conclusions that we do draw are very well supported. With epidemiologic studies, there's always going to be an element of inconsistency whenever you're studying walking, talking human beings. Experimental studies are much more controlled, but in terms of kind of following large groups of populations over time, you always get inconsistencies. And certainly I've been involved, I think, in firefighter cancer studies in 4 different jurisdictions. And I often show people a graph to show that studies that I'm involved in are not always agreeing, but sometimes they do coalesce around certain things. So that is really where we're looking at in weight of evidence. I agree with many of the things that Daniel said. I'm not sure if I can address any of those, and if maybe other folks who are involved can have something to say.
Deborah,
Yeah, I mean, the one thing I would say is, I agree that the focus needs to be on cancer reduction, exposure reduction, looking at, incorporating hierarchy of controls. The IARC monograph has an entire section devoted to that. And there's a lot of other efforts around that. I think it's important to look at cancer risk in conjunction with, cancer reduction, because a lot of times, we think we're doing the best thing in reducing exposures, but we don't know what the long-term implications are with respect to cancer risk. And so that's one of the big objectives of the National Firefighter Registry, actually, is to try to tease some of that out and learn from it. And then I think we can learn something that extends even beyond the fire service by doing that.
But I just wanted to add that one of the reasons why this kind of work is important is that money won't be spent on mitigation unless you can show that there's a risk. That's one reason why it's important. The second thing is that these are people who risk their lives to look after the rest of us. And I think, there is some duty of care that the society owes them to look at the problems. The other, part of the difficulty of it is that exposures have changed over time. So PFAS foams are no longer used for firefighting in most circumstances. Now in Australia, people used to take off or not use protective equipment when they were just after they'd done the knockdown phase, after they did the kind of cleaning up phase, but it's been shown with measurements that is still giving off quite a number of nasty materials, and so it changes behavior. So you can, but it does complicate the matter when you're looking from one study to another. We did note in the monograph that most of the firefighter studies have been done in first world environments. There's very little known about firefighting in the developing world and the kind of exposures that go on there. So there is still a bit of a gap in the literature. It's fairly obvious that, you know, if you rush into smoke, you're going to be at risk, but you know, so in that sense, it's not known. But there are so many different exposures that it's hard to know which of them are the ones that should be focused on in terms of control measures. And you know, you've got heat, you've got carbon monoxide, you've got the burning gases. I mean, there's a whole list of different things. So, you know, where do we focus our control measures? And there is work done in particularly not the kind of study I do, but in terms of metabolic reactions that may help track that down, and they were used in the IARC study as the mechanistic data.
Can I ask if Chris Ide is still with us? Can you ask your question? Also identify yourself.
Hello, good morning everyone from sunny Scotland. My name is Chris Ide, and for 11 years I was the medical advisor to Strathclyde Fire and Rescue Service, which was the second largest of the 55 local authority fire brigades in the UK. And I've carried out some research into firefighting, which has been published. And my question was, have any of the studies looked at occupations that the firefighters pursued before they joined the fire brigade? What made me think about that was we used to X-ray firefighters when they left the service, amongst other occasions. We did a chest X-ray on them, and when I was looking at these results, 8 of the firefighters had radiological evidence of pulmonary fibrosis. Now, none of them had any symptoms or were retired because it was 8 had pulmonary fibrosis. And I was able to access the recruitment documentation for these firefighters, and 4 of them had occupations which screamed exposure to fibrogens. One was a lagger, one was an insulation lagger. Another one was a labourer in a moulder in a foundry. A third was a quarry labourer, and the fourth was a joiner in the shipyard. The reason I couldn't find anything out about the other 4 was because I didn't have the time to work my way through mid-1950s trade directories in the local reference library.
So, try to make your questions brief and your answers brief too. Anybody want to respond to Dr. Ide?
Well, you know, we do ask in the firefighter registry about other jobs that firefighters have held, and you know, in the United States, many firefighters, and I'm sure it's true in other countries, have hold other jobs, second jobs, or had a job and then, you know, join the fire service, or they're career firefighters and volunteer firefighters. So I think it is important to try to capture that. It is really hard to study it though. So we're going to try to capture it and try to make sense of it in the firefighter registry, but you know, it's a difficult data to really examine.
Richard Campbell has a question, please. Richard, are you still with us? The answer is you have to unmute if you are. If not, we'll go to the next person. Peter Jamarillo, I believe, and my apologies for mispronouncing your last name. Jamarillo. Okay. Kevin Hedges has a question. Dr. Hedges, please.
Yeah, great presentations, everyone. Fabulous webinar. Thanks so much for pulling this together, David. My question was with Dr. Kenny Fent. With the questionnaire, it looks like a pretty extensive questionnaire, and it has to do with, you know, there's a great opportunity to even kind of almost use it like a bit of an audit desktop tool. You know, if you're, you know, I'm just wondering the extent of the questionnaire. Like, have you engaged with, you know, respiratory protection experts, you know, and looked at, say, standards and elements of a program, and try to tease that information out with the questionnaire as well?
Yeah, to some extent. So we have an advisory board that helped us that has fire service and scientific, experts on it. But we do ask questions about PPE when certain, types of PPE were, begun to be worn, certain standards. So we are trying to capture as much as we can, but we also had to kind of weigh that with the length of the survey. So if there are certain questions that aren't asked that should be asked, we can do it in a follow-up questionnaire. But the initial questionnaire does ask a lot of questions about PPE.
Thank you.
Robert Brandeis, are you still with us?
Yeah, I'm still here, but not sure if I can get a picture.
Give us your question, sir.
Well, my question is, has anybody looked at the subgroup of 9/11 emergency responders since they were exposed to significantly high levels of both silica and asbestos as well as combustion products? They are a biased subgroup that had long-term high-level exposures, and given the million firefighters you're looking at, this is a subgroup that might be worth special study because they do have a significant disease history and their exposure levels are fairly well documented, but some of that stuff, some of the data was classified.
Yeah, so there's a go ahead, Deb.
Go ahead. No, you go ahead, yes.
I was just going to say it's probably the most studied worker population in the United States, and we actually have the World Trade Center Health Program that NIOSH leads, and so they've been following the responders and other individuals who were exposed for quite some time, and actually we've learned a lot by doing that.
So what's the cancer risk in that subgroup?
It is elevated for a number of cancers.
And how does that relate to the IARC data in terms of the carcinogen classification? I mean, does it follow it or does it not?
The IARC evaluation considers all the evidence, not just rating on one study. It is in the IARC monograph. The studies are described and were considered, but it's not like that was given a special weight. For one thing, they have not been followed up for the length of times of other firefighters. I mean, that's all I say. They were part of the evidence that we reviewed.
Okay, thank you.
The next one is Bernie Fontaine, please. Got a question? Again, unmute.
Good evening, everyone. I didn't really have a question, but one of the things I've noticed through the fire service, I've worked with them for a number of years, is that technology has not stayed current. There is new technology to fight fires rather than putting firefighters in harm's way, and I think we need part of that is an educational process. But many of those firefighters put themselves in harm's way for rescue and search and so forth, and we need to really look more closely at those data. I think it's very important registry.
Yeah, I think that's a good point. And the next question comes from Danny Santoli. Again, I apologize if I'm mispronouncing your last name. And if you're with us, please unmute and ask your question.
Hi, thanks very much for your time. This presentation was awesome. I have a quick question. Here in Ontario, Canada, the compensation boards put latency timelines on specific cancers, i.e., for example, bladder cancer, you have to work 15 years as a firefighter to get the cancer approved because of presumptive. My question is there any studies out there that have conducted cancer latency timelines? I haven't found any. I've looked through many of the major studies like the NIOSH study, the Australian study, the Korean study. How do these boards, these government boards, come up with cancer latency timelines? Thanks very much.
There are generally accepted timelines for specific cancers. So blood cancers tend to be have about a 10-year latency from first exposure to development, whereas something like mesothelioma typically is 30 or 40 years. So there are and they would be timelines developed not from the firefighter studies, but from studies of other workers, so asbestos workers, for example, where you get a much this is going to sound wrong, a much cleaner exposure. So, asbestos workers have had asbestos exposure, and when they started, it's more difficult with firefighters because they have so many different exposures that penning a timeline, is just a much more difficult thing. So it comes, I think, from epidemiology studies from elsewhere.
Yeah, and again, may I suggest to people that if you get the larger IARC monograph, and I believe it's free, you may be able to get some answers to some of these questions that have been posed. Some of them are specific to research that has been undertaken, and in some cases there may be data that are responsive to your questions. The next question came from Brian Harriam. Brian, are you still with us? And if so, unmute, please.
Yeah, first of all, thanks to WHWB and to each of the presenters. I just noticed that in a couple of the presentations, I think from IARC and Australia, that lung cancer appeared to have a lower risk of cancer. And I was wondering if there are any explanations or thoughts about that particular cancer having a lower risk than other cancers.
I think that there are often more than one risk factor that lead to particular cancers. And for smoking, for lung cancer, smoking is a much bigger risk factor than almost any others that we know. But unfortunately, the kind of data that we get from employment records doesn't include individual smoking data. So there is an assumption that firefighters are likely to smoke less than the general population, perhaps in order to maintain their fit and conscious. So the suspicion is that they smoke less than the general population, resulting in a lower background risk. And there is some evidence from surveys separate from the epidemiology that that's true. Perhaps less so for female firefighters than for male firefighters, but that's thought to be the explanation, because I agree with you, it doesn't at first sight make sense that someone who inhales smoke would have a lower, firefighting smoke would have a lower risk than the general population. It is a kind of counterintuitive, but that's thought to be the explanation. But I think Kenny's study that will collect those individual risk factors will be really important in picking that out.
Yeah, I'll also say that there's a limitation in a lot of the firefighters, and Debs is an exception, of having much in the way to assess whether to look at just firefighters who've been to a lot of fires, or it really is it's fairly challenging there. So there may actually be some groups of firefighters that have an increased risk of lung cancer. But when you look overall at firefighters, I think what we're seeing is, potentially those, potentially lower smoking rates, potentially some element of the healthy worker effect. The kind of people that are recruited into firefighting probably have to have pretty good health in the first place, and that would be, especially good health for firefighters. So there's a lot of factors that go on with this, unfortunately, that sometimes make it hard to identify what the real risks are.
Thank you.
Yeah, I think your question is quite a strong one, given the fact that there's this elevated risk for mesothelioma. We would have expected that the lung cancer risk, because of the presumed asbestos exposure in firefighting, might have been elevated, but that has not, as Dr. Demers just said, that has not been borne out by the epidemiology studies. So a good question. We need to keep this going and continue to ask these questions and ask the data why. things are showing up the way they are. Next question comes from Douglas Swift. Douglas Swift, are you with us?
Absolutely, absolutely. Very interesting discussion. I've always enjoyed going over the IARC monographs. I find them very valuable in my work as an occupational physician, and having been the medical director of a number of emergency response teams and largely petrochemical plants where they do work already around chemicals, and then when there's a fire, they then turn into firefighters and EMTs, and we have to work through those things. But I was curious about the discussion on shift work and sleep disturbance as a risk factor. I look forward to reviewing the monograph. If that's covered in the monograph, I'd be interested in what the evidence for that is.
I don't mind. So shift work has been primarily associated with increased breast cancer in women. And there's some suggestion of prostate cancer increases in men, and that would kind of fit with the data. The problem with the breast cancer is there have been very few studies of women firefighters to assess that risk. And secondly, a very big risk factor in women is exposure to female hormones. So if you've had a lot of children and breastfed them for a long time, you will reduce your risk of breast cancer. But of course, women who've had a lot of children and breastfed them for a long time are rather less likely to become firefighters. So you've got difficulties in making sure that you're comparing like with like in terms of breast cancer risk. So the effect of shift work will probably be small in comparison to the effect of female hormones. So, it's going to be a tricky one to pick out, I think, in epi studies.
Thank you.
Again, maybe Kenny's work will take into account and answer some questions. So we're looking forward to finding those answers.
Absolutely. Well, I teach at the Tulane School of Public Health, and I teach my students to review the Bradford Hill criteria. In fact, I test them on it. And I also point to an old work back in 1981, Dolan Pito's work on the preventable causes of cancer in the United States, which point to certainly environmental factors, including diet. But thank you very much to the panel. It's been a very interesting evening.
Yeah, I'd like to ask Marie Elena Dryden. Oh, Pablo Ochoa had a question. Sorry. Pablo, are you still with us? I'm afraid not.
Sorry, my English not good, but if you can read, please.
Sure.
Thank you, sir.
Pablo says, we firefighters don't like to read, let alone negative topics that address our health. It's something cultural in the US and Australia and Panama and so on. Have you thought about creating a simple or practical newsletter that translates such valuable information into more practical or operational language? Maybe you are just not responsible for doing this. I just want to know if it exists or it can be made. I am aware, and Dr. Fent knows this too, that firefighter unions have tried very hard to give information to their members. And if you will send me an email, I will send you the name of the local firefighter union association here in Washington, D.C., and I will give you my email in reply to yours. So the next question is from Marie Elena Dryden.
Thank you, sir.
Thank you.
Hello. Dr. Goldsmith.
Hi.
Yeah, this is Mike Dryden.
Okay. Go ahead, Mike.
My wife, I'm on my wife's computer. That's why it sums up Maria Elena. So
okay.
Sorry for the confusion. I'm an attorney in Pennsylvania. You and I have actually met, Dr. Goldsmith, a couple of times.
Right.
My question is, I guess, for all of the experts on the panel, how do we take, or where do we go for information about taking the work on the general causation level regarding the mechanistic causes of cancer being increased for firefighters, and then correctly boil that down into a specific causation opinion about one specific person or one specific firefighter? What's the process, or what are the guidelines? How is that best done with this new information? Because I see a difference in monograph 98. Didn't really talk much about the mechanistic increases for firefighters as compared to monograph 132. So I'm in particular interested in learning how to take that information and boil it down to a specific causation opinion in the most fair and accurate way.
Paul, do you want to answer that?
Thanks. That's a really challenging question. I mean, I don't think the science is there yet. In the case of this, what we're looking at is, with many of these studies, is that they're examining people before and after fires, for example, is one of the designs. And then they're seeing these kind of markers of carcinogenic effect coming up in those firefighters. But those are things that don't last for the next 20 years, that you can simply measure and say, yes, oh, this person has this, and then it means it's firefighting. I don't think the state of the science is there. It really is really looking at still at the epidemiology and the overall increased risks in different groups and tying your evidence to that. I think that these studies of mechanisms are they do help us identify groups at high risk. I think they're great to help drive prevention, because you can tie it to what the people were doing on the day or over the course of the work shift and say, well, this is associated with higher effects. But I don't know if it really adds a lot to compensation per se. I don't know if anybody else has a different opinion on that.
Well, that was my sense of it too, that you have to look at the data and see what it tells you. This new IARC report is very comprehensive. It looks at a very wide variety of epidemiology data, including these meta-analyses, and it looks for consistency. That's one of the important points about the IARC review assessment, and understanding an individual, how that fits with the epidemiology data. That's part of the goal of trying to use these kinds of data for compensation issues. And I know it's very frustrating to take a look at these kinds of things from, if you will, either close up or very, up at a 30,000 foot level. But nevertheless, I mean, that's what the compensation interaction requires us to do. So let me continue with these questions. Alec Farquhar, who is one of our leaders and supporters, he has a question. Alec, go ahead.
Here we go. I'm interested in knowing, maybe from Paul, maybe from others, how many of the studies come from developing economies and what we might consider to be precarious firefighting situations? I'm quite familiar with firefighting hazards in Canada, for example, and they have been mitigated, at least to some extent, by prevention measures, different kinds of protective gear, et cetera, et cetera. So the combination of, are the hazards and the exposures any different, and the protective measures different? And it, of course, making me wonder whether the hazards in the developing world might be very significantly greater.
It was, I was part of a group, my center and Health Canada co-sponsored a workshop on firefighter cancer research priorities. I put the link in the chat, and I'll I'll probably just add a slide before we post the slides so that people want to see that. It is one of I think the major gaps that's there. I mean, there are a lot of major gaps in firefighter research in terms of the studies of cancer in firefighters. They're primarily, with some exceptions, Australia being one of the best exceptions, where they've looked at more than just urban firefighters, but there's a lot of structural firefighters are the major group that's been looked at in high income countries. And so we don't have it in low or middle income countries. We don't really have studies. We have very little data, again, with the exception of Australia and maybe one or two other studies that have looked at volunteer firefighters. Wildlands firefighters or forest firefighters in a lot of countries are extremely important. In a way, they may have conditions that might be somewhat similar to folks in disaster situations or in low-income countries where you have to fight for prolonged periods with very, very poor personal protective equipment, almost nothing there compared to what some of our studies are of. So these are major gaps in really understanding the broader risks in firefighters around the world and in different groups of people.
Great, thanks very much.
Yeah, Albert Donnie has a question. He's got his hand up anyhow. Sorry, go ahead.
Yes, thank you. My question is for Paul and others familiar with the IARC review and the Canada review. Was there any discussion of the evidence that carbon monoxide exposure is carcinogenic?
No, I don't believe so. I'm not aware of I mean, I would suspect that when there's carbon monoxide exposure, there can often be combustion of other things. And that's probably would be my major concern with carbon monoxide. I'm not aware of any evidence myself, and maybe I'm just not aware of it, of carbon monoxide being carcinogenic in and of itself. But it would be there in a lot of situations when anything is being burnt, including emissions from vehicles, including diesel or even gasoline, as well as fires and other things like that. And there are no, and that certainly wasn't part of there was a lot of studies considered in the IARC evaluation, but it was really limited to people who were exposed to fire smoke.
Right. Dr. Hedges, you have your hand up. Please give us your question.
Oh, yeah, it's just asking a question for Michelle Chu. So Michelle's an occupational health nurse from the Occupational Health Clinics for Ontario workers. She doesn't have a microphone, so she asked if I'd ask the question for her. And just want to say it's great to see you, Deborah, to co-present along with the others. It's really nice to see you. So the question it's kind of looking at through the prevention lens, and Michelle's question has to do with, along the line of Mr. Samo's comments, have trends over time shown a decrease in cancers vis-a-vis use of health and safety efforts? So has the analysis actually gone that deeply to actually look at trends over time with different health and safety efforts? So that's the question.
Well, that's really difficult because there have been so many different changes going in different directions. So, you see more things in building fires. You see different things in car fires. We're now a bit worried about the fires in electric vehicles, which are particularly hot and give off a lot of nasty stuff. So there have been changes in both directions. So although there's been more emphasis, for example, I mentioned earlier, we try and make sure that firefighters are protecting themselves with personal equipment after knockdown, which they didn't used to do. But this is such a moving feast. It's almost impossible. But I think that's partly why the monograph was about being a firefighter, not about any one of the exposures. So the exposure section tried to cover all the different exposures, but they've been moving in both directions, as well as personal protective equipment. I think the biggest gap in terms of personal protective equipment is likely to be the Whwb or wildland firefighters who are out there for perhaps days on end, and it's difficult to provide them with adequate protective equipment over all that time. I think that's a big, and obviously with climate change, that's going to become increasingly important. We've seen already the bushfire seasons have extended, so that the loans that used to happen between Australia and North America have become more difficult because the seasons are now overlapping more. So yeah, it's such a moving feast. Sorry, can't help you much on that one.
Thank you.
So then I have one more question from Mr. Ochoa. He wants to know, are the results of your studies being considered by manufacturers of personal protective equipment for firefighters or NFPA, National Fire Protection Association, for updating standards? And I presume the answer is yes, but I don't want to speak for you.
So, I mean, in terms of the exposure assessment research that's been done at NIOSH and other academic researchers, NFPA is looking at all that data. A number of actually positive changes in the fire service are because of the research. So, for example, we have particle blocking hoods now that are being developed by manufacturers. Turnout gear that has tighter interfaces around the wrist and waist and neck to help with prevent some of the ingress of the contaminants. Turnout gear gloves that are easier to decontaminate. So there have been a number of PPE advancements that have been made because of the research. And then in terms of decontamination recommendations, or guidance, I should say, NFPA has adopted a lot of that based on research as well, and that's continuing to evolve.
Well, speaking of continued involvement and evolution, I think we've come to the end of our session, and I really want to thank directly Dr. Kenny Fent, Dr. Deborah Glass, and Dr. Paul Demers, and all of you who joined the Zoom. Thank you so much for your attention and for your excellent questions. And if anyone has any additional questions, feel free to contact me and we'll try and get them to the right people. But have a very nice evening, except for all of you in Australia. Have a good day, as they like to say down there. And we hope that your summer is not one where you have a lot of wildfires to deal with. And thank you again for everybody. Really appreciate it.